So first of all, we have hypertension, okay? Biggest issue in cardiac system, okay? How do you diagnose? The first question, how do you diagnose someone with high blood pressure? So if they come to you in the office visit, first time they come to you and you see high blood pressure, okay? You let them go, let it go. Next time they come to you again, they have high blood pressure. They never been diagnosed with high blood pressure, okay? And this is second time they come to you, this is high blood pressure again. So that time you can tell them that, I am diagnosing you with high blood pressure today, okay? Because this is second time I'm seeing this. Every time when you come, this is second time your blood pressure is high. So you are officially now diagnosed with high blood pressure, okay? What is the definition? What is the number you are looking for? Okay, so normal blood pressure is 120/80, okay? That is normal. 120 systolic, 80 diastolic, 120/80 normal blood pressure, less than, okay? So stage 1 blood pressure, 140 to 159. So basically 140 to 160, that is your stage 1, okay? Stage 1. And that is systolic blood pressure. In diastolic, you have 90 to 99. That is diastolic number. So 140 to 159 systolic, 90 to 99 diastolic, that is your stage 1 blood pressure, okay? So if it's above 160, that is, blood pressure that is uncontrolled high blood pressure, okay? Above 160, if they are kind of hanging out, or most of the time 170, 180, that's uncontrolled high blood pressure. If they are going to emergency with blood pressure above 200, there is hypertensive urgency, okay? Above 200, there is hypertensive urgency. So for those patients, they have to stay in the hospital. They have to get on some blood pressure drip to bring that blood pressure down. Then at the end, they're gonna take this multiple blood pressure medicines, okay? If their blood pressure is kind of hanging out above 200, that is really bad. That patient can have, kidney disease afterwards, because it affects, the blood pressure affects their kidneys, okay? Ultimately, they can have kidney failure as well. So patient who is old, they are like, if they are greater than 60-year-old, okay, their blood pressure goal should be less than 150/90. That's what their goal should be. If patient is less than 60, but they have other disease condition, where they have kidney disease, diabetes, all of this patient, their blood pressure goal should be less than 140/90. Okay. So how do you treat? Now you diagnose this patient with high blood pressure. Now it comes to treatment. How are you gonna treat them? So for anybody, I would say initially you would use thiazide diuretics, okay? Initially you're gonna use thiazide diuretics, okay? What is thiazide diuretics? HCTZ, okay? Hydrochlorothiazide. It's a thiazide diuretics. So either it's African American, it's white population, anybody, you're gonna use thiazide diuretics. So thiazide diuretics is not actually blood pressure medicine, okay? It works to pull the extra water out of the body. Okay, so it's diuretics basically. That's what you're gonna give them initially. And then second is you can do calcium channel blocker, okay? Calcium channel blocker, that can be your nifedipine, amyloid pen, all the dipins, okay? All the dipins you can do. That is calcium channel blocker. You can do thiazide diuretics for anybody. So look at right here. African American patient or white population, okay? Anybody you can do thiazide or calcium channel blocker. For non-black, okay, any other community people, they can use thiazide diuretics, calcium channel blocker, AC inhibitors, ARB blockers. So basically they can use anything. So for the exam, first choice of treatment, either African American or white population, what do you do? Thiazide diuretics. HCTZ, the lowest dose, which is 12.5 daily, okay, to begin with. It depends if patient is a little bit obese, okay. If they have other something going on, if they have diabetes, you know, then you're gonna give them a little bit higher dose, because tiny puny dose is not gonna help them. So at that time you just have to, you know, use your judgment in that. So initial dose 12.5 daily, okay. The max dose of thiazide diuretics HCTZ they can take, you know, 25. However, in the real world, you may see patient, you know, they're taking 25 in the morning and 25 in the evening time. That doesn't work that way. They can take maybe, you know, 100 milligram, but only their body's gonna absorb, which is only 25 milligram. So rest of them, you know, is not even helping them. So why bother prescribing, you know? So just only do 12.5 or 25, that's it, okay? The next one is your Amyloid Pen, okay? Amyloid Pen, that is calcium channel blocker. Nifedipine, calcium channel blocker. For patient who has isolated systolic high blood pressure, elderly patient, they don't have nothing else going on, you know, they just have this systolic numbers are up, upper number are up. For those patients, you can do calcium channel blocker. Amyloid Pen works best for them, okay? So when you prescribe Amyloid Pen, you have to consider some side effects. Amyloid Pen can give them ankle swelling, not bilateral lower extremity swelling, okay? It's gonna be only ankle swelling. So remember that. You just tell the patient, you know, I'm prescribing this newer medicine. You always have to explain to them side effects and benefits and everything about the new drug. But you also have to tell them that, you know, you may experience this ankle swelling in 1 or 2 weeks. And if you do, let me know. I'm just going to change it to different class of drug, okay? But for elder patient who has only thing is systolic blood pressure elevated, you can do calcium channel blocker. You can do nifedipine, you can do Amyloid Pen, anything with dipin you can do, okay? So this is right here, calcium channel blocker, Amyloid Pen, or nifedipine. So again, thiazide diuretics, that's the first one you're gonna choose, okay? So there are some consideration you have to follow. So if you're prescribing this medicine, okay, if patient is allergic to sulfa drugs, you don't prescribe this thiazide diuretics, okay, because it's contraindicated. Thiazide diuretics has a little bit sulfa contained in it. So, you know, if patient is allergic to sulfa, you don't prescribe HCTZ. Main side effect for the exam, you have to remember. So they like to ask this question, side effects of thiazide diuretics, okay? In the multiple choice, they will give you all the other options. You have to remember this highlighted thing right here. It brings down everything, hypo, okay? All the electrolytes, hypo. Remember this, hypo, hypo, hypo. All the electrolytes goes down with HCTZ. Because it's a diuretic, so they're gonna pee out sodium, you know, potassium gonna be low in the blood vessel, sodium gonna be low, magnesium gonna be low. On the other side, it increases their blood sugar, okay? So remember this. If it increases the blood sugar, would you give this medicine to diabetes patient? No, because it increases the blood sugar, so you have to be careful. The other thing, it increases the uric acid, okay? So here your another consideration. Would you give this medicine to patient who has gout or history of gout or acute gout flare-up? No, because it's gonna increase the uric acid. So you don't wanna give this to patient who has gout. And it also causes, you know, high lipids. So on the other side, if patient has terrible hyperlipidemia, don't give this medicine, okay? So main three side effects you have to remember, that's gonna bring down all the electrolytes. Mostly sodium, potassium, magnesium, okay? That is main thing. So good thing is, if patient has osteoporosis or osteopenia, they can take this medicine. It's good for them because it decreases the calcium loss and you know, it helps with demineralization. So that's why it's good for patient who has osteoporosis, osteopenia, okay? Let's move on to the next one, calcium channel blocker. That ends with pine at the end, okay? nifedipine, amlodipine. So good thing is amlodipine, nifedipine drops the blood pressure, help decreasing the blood pressure. It does not affect the heart rate, okay? So the other one, calcium channel blocker, that is verapamil and cardizem. It also known as diltiazem. So verapamil and cardizem, okay, it does drop the blood pressure, but just a little bit, okay? It drops the blood pressure a little bit, not as, you know, amlodipine and nifedipine would do. But most of the time, they use this cardizem to bring the heart rate down. Also, verapamil they use to bring the heart rate down. You have seen both of this medicine, they use it for the blood pressure as well, okay? But mainly it uses to lower the heart rate, basically. Here, this nifedipine, amlodipine, okay, it does not hurt the pulse. But cardizem, verapamil decreases the heart rate, decreases the blood pressure as well, okay? So the other thing here, you have to remember that I told you already that amlodipine gonna cause them to have ankle swelling, okay? So calcium channel blocker, you have to avoid for the patient who has heart failure going on. Heart failure, different criteria, right? Heart failure, how do you decide that they have heart failure? You order the echocardiogram, you look at the EF, ejection fraction, okay? That's what you look at. So if it's less than 40, okay, that is systolic. If EF is greater than 40, that is diastolic, okay, diastolic heart failure. So less than 40 EF, you know, avoid this calcium channel blocker. You don't want to give this because it can exacerbate heart failure, okay? So the other thing you want to avoid calcium channel blocker, which is your cardizem and amlodipine, all of the above. You want to avoid those medicine in patient who has GERD, okay? Because GERD patient has this loose LES, okay? The valve LES is loose. Sphincter muscles, that is loose. And all the acid is coming back from the stomach to esophagus. What this cardizem or amlodipine does to the patient who has GERD, it relaxes the LES, okay? It relaxes more. So you're gonna get their GERD worse. Acid reflux, they're gonna have worse ever. So that's why you wanna avoid that. Next one is AC inhibitors and ARB blockers, okay? Those are your prios. AC inhibitors is your prios. ARB blockers is all the sartans, okay? Olmesartan, losartan, all the sartans. So what you have to remember here. So if you're prescribing, let's see, for example, if you're prescribing lisinopril, okay? And after taking lisinopril, 4 to 6 weeks, okay? If patient's gonna have cough, it's gonna take a little bit longer. It's not gonna have cough. They're not gonna have cough after 1 week taking lisinopril and they don't complain of cough. So after 4 to 6 weeks, if they complain of dry, hacky cough, just dry cough, you know, then you consider that this is side effect of lisinopril. So you tell the patient, okay, when you prescribe it, you know, you have to tell the patient that you may experience dry cough, you know, and if you do, let me know, I'm gonna change it to different medicine. So now they're telling you that, yeah, I do experience cough. So then you wanna change it. So you can stop lisinopril that time, and then you can add losartan, okay? Lisinopril works on the renin-angiotensin 1, and then losartan, okay, ARB blockers, works on the renin-angiotensin 2 in the kidney, okay? So if they complain of cough, you say, yeah, okay, let's stop this lisinopril and I'm gonna add losartan, okay? Type 2 thing we're gonna add, losartan. So if you're prescribing lisinopril to another patient and he said, oh my God, he has to go to the ER because of the angioedema, okay? Lip swollen, tongue swollen, throat swollen, you know? And then you never ever gonna prescribe them lisinopril again because you don't wanna jeopardize their health and life, okay? So you never ever prescribe lisinopril, any kind of prio, you never gonna do, okay? Along with, you're never gonna prescribe an ARB blocker either, because If patient is experiencing angioedema with AC inhibitors, most likely they're gonna experience angioedema with losartan or ARB blockers as well, okay? So angioedema, don't worry about anything, okay? Don't worry about AC inhibitors, don't worry about ARB blockers. But if they only complain of cough being on lisinopril, yeah, you can stop it and you can prescribe, losartan, that's fine. The other thing you need to know is, if patient, you're going to prescribe them this lisinopril or losartan, you have to get their baseline kidney functions, because those medicines are nephrotoxic. Of course, it works on the kidney, but those are nephrotoxic as well, okay? So you have to know what their kidney function is before you initiate. So you have to get the chemistry first, okay? CMP, full panel, you have to get. And then you have to get their baseline potassium as well. You need to know what is their baseline potassium, because those medicines gonna increase their potassium in 1 to 2 weeks. So after 2 to 3 weeks, you have to repeat the CMP again to check and see how their potassium is. Because one of the other side effect is hyperkalemia. So you prescribe it, you keep on the potassium, and if it doesn't increase, then you just continue going. But if that patient experience side effect, which is hyperkalemia, then you back up the dose or you completely stop it. It depends. So that's that. Next one is beta blockers, okay? So main thing you need to know about beta blockers is it decreases the heart rate, okay? If patient has appropriate sinus tachycardia, okay, their just heart is beating faster. There's nothing else going on. It just beats faster. Somebody is having anxiety attack, heart's gonna beat faster. But any kind of other situation as well. If they have tachycardia going on, you prescribe beta blockers to bring the heart rate down. Also, this is not the first choice of treatment. This is not the first choice of treatment, okay, for blood pressure. This may be like fourth choice of treatment, okay, fourth or fifth. So it's best for the patient who has, history of stents in the heart, who has bypass done in the past, who has, history of MI, heart attack in the past. So it's best for those patients. Also, it can be used for migraine headaches, okay, prophylaxis treatment. Patient who has glaucoma, glaucoma, what is going on there? Patient has this increased IOP, intraocular pressure goes up. So to decrease that pressure in the eye, beta blocker, which controls the blood pressure and brings the heart rate down. For those patients who has glaucoma, they use that timolol, okay, olol at the end, timolol eye drops. That's for the glaucoma. So beta blocker can be used for glaucoma as well. Sinus tachycardia, they use that. Patient who has a hyperthyroidism, okay, everything is hyper. Hyperthyroidism has panic attack, anxiety, SVT, AFib, palpitations, everything going on. So beta blocker would help them, okay. Pheochromocytoma, those patients also, because of the tachycardia, and pheochromocytoma has low blood pressure, high heart rate, okay? So you have to watch their blood pressure as well. But beta blocker is choice of treatment for them as well. Your consideration here. Consideration is, if patient has, heart block, you don't want to block their heart anymore, okay? Heart block, grade 2, grade 3 heart block, it's contraindicated because they're going to have bradycardia episode. Maybe grade, complete heart block, those patients going to hanging out in the heart rate 30s and 40s. You don't want to bring it anymore, any down, okay? So that's why you don't give those patient beta blocker. For patient who has asthma, COPD, if they have severely restricted or obstructive lung disease, you don't give them beta blockers, okay? So it's contraindicated. Next one is alpha-1 blockers, which is your Zosyn at the end, okay? Here you have to remember, for the exam, you have to tell the patient, what is your Zosyn right here? It's a Tazosyn, okay? Tazosyn, Zosyn group of drug. alpha 1 beta blocker. Whenever you give this medicine to the patient, you have to tell them that you may experience first time, when you take it first dose, you may experience low blood pressure. So whenever you take it, you consider that, and you don't, jump up out of the bed. You take your time, you sit, relax, and then stand up, okay? And also, of course, monitor the blood pressure. The other thing is, it's good choice of good choice of drug. Remember this for the exam. Good choice of drug for the patient who has benign prostatic hypertrophy. Okay, the prostate gland is becoming enlarged. Okay, so patient who has high blood pressure and BPH, because terazosin is drug to treat BPH. Okay, and Flomax, psilocin, Flomax basically. Flomax is used to treat BPH as well, but it only treats BPH. It doesn't take care of the blood pressure. But terazosin, good choice of drug, good treatment for the patient who has combined problem. Okay, they walk in, they have high blood pressure, also background history of BPH. Then this is the good choice of treatment for them. Remember this. Next one is diuretic. So this is not blood pressure medicine, okay? It's a diuretics. It's a Lasix. Other group of drug, you have Lasix, you have Bumax, Bumatidine, Lasix, which is furosemide. So this is all diuretics, okay? It's not blood pressure medicine, but when they pee out all this urine, urine comes out, blood pressure drops a little bit. So that's why patient who has hypotension, make sure that you are decreasing the dose of Lasix, or sometimes you have to stop it because of the low blood pressure, because it's gonna, bring the blood pressure down a little bit. So it's not the blood pressure medicine, but it's the first line treatment for heart failure. Because what's going on in the heart failure? Their heart muscles is weak. They are just giving out. Their heart is giving out. So that's why they are getting all this puffy feeling, swelling in their legs, fluids backs up in the lungs, all that. So they need some diuretics help, okay? So that's why Lasix, Bumax, it's helping them. So Lasix, initially, that's what you do. If they are coming with heart failure, you get their BNP, which is specific blood test to check the status of the heart failure. So you get that, and if it's elevated, then you prescribe Lasix. You also have to watch their kidney function and all that. But Lasix to begin with, that's what you do. However, if some patient is taking Lasix forever, they're gonna have resistance to Lasix. Then you're gonna, at some point, you wanna change it to Bumax, because Lasix is lighter, Bumax is stronger, okay? 20%, 20 times stronger. Bumax is 20 times stronger than Lasix. Okay, so side effect, again, same thing. Low potassium, low sodium, low magnesium. Same side effect that Thiazide diuretics has, right? They're peeing out all this, electrolytes. Okay, next one we have is aldosterone receptor antagonist. What is that? It's your spironolactone, okay? Spironolactone is a good choice of treatment. This is a patient who has, every time they have this hypokalemia going on, they are having diarrhea or vomiting, stuff like that. For those patients, if they need help of medication, if they are in heart failure, stuff like that, then you can choose spironolactone, okay? Because it's potassium sparing diuretics. It helps to store potassium in the body, okay? So that's why you can use this. Spironolactone, it's a potassium sparing diuretics. It's not a blood pressure medicine, but of course it's gonna help blood pressure to come down some, okay? It's a choice of treatment mainly for heart failure, okay? Heart failure. So heart failure, initially you're gonna do ARB blockers or AC inhibitors, then you can add beta blocker, step-by-step treatment. Then you can add beta blockers, then you can add, Lasix, diuretics. If that doesn't work, then you can change it to Bumax. Then you can add spironolactone. So it's step by step, okay? So it's a choice of treatment for heart failure. Patient who has hirsutism, okay, extra hair, those patients can take spironolactone as well. Main thing you have to remember for the exam, okay, what is the side effect of spironolactone? So side effect, galactorrhea, gynecomastia. Gynecomastia, that is enlarged, bigger breast, okay, in the male. Galactorrhea, that is like milk coming out of the breast, okay, that is galactorrhea. So you have to remember those two things. GG, spironolactone side effect, GG, galactorrhea, gynecomastia, okay. Side effect, because it's potassium sparing diuretic, is gonna increase their potassium, okay. Patient also has some GI upset with the spironolactone. Again, you have to remember that AC inhibitors and ARB blockers also increases the potassium. Spironolactone also increases the potassium. So everything's gonna increase their potassium. So of course you have to get CMP or BMP, right, to check their potassium. Okay, next one. You have to remember, if patient who has uncontrolled high blood pressure going on, hypertensive crisis, anything, those patients are high risk to have some kind of eye problems, okay. Those patients can get, it's called AV nicking, okay, that is artery and vein crossing over each other. That is AV nicking. So right here in this picture, AV nicking is right here. Artery, this is artery right there, this is vein crossing over each other, okay. Then they have this retinal hemorrhage. So what is retinal hemorrhage? So in the eye they have this tiny little vessels, okay. Those are because of the high blood pressure just busting open, okay. They are just busting. So that is hemorrhages, retinal hemorrhages. Copper silver linings, okay. This is right here, copper silver linings, right there, copper silver linings. So remember this three main fundoscopic exam thing, okay. In the exam they will give you that patient has, chronic uncontrolled high blood pressure, and what three things you're gonna, if you do fundoscopy exam, what can you see, okay, what can they have. So AV nicking, retinal hemorrhage, copper silver linings, remember this. So next one, diabetes, fundoscopic exam for uncontrolled diabetes patient, okay. Cotton wool spot, microaneurysms, neovascularization, okay. Neo, that means new, okay. New vessels occurs in the eyes. Micro, which means small, small, small. Aneurysm, blood vessel, let's just guess that this is blood vessel in the eye, okay. Aneurysm, that is just a little bit bulging out, okay, popping out, hanging a little bit, that's aneurysm, okay. And then cotton wool spot, big white color spot, okay. So the way to remember this, diabetes, don't get confused with hypertensive retinopathy and diabetes retinopathy. So for diabetes, when you check patient's blood sugar, you prick their finger, okay. So you prick that finger, so I would say that you use that cotton swab, okay. So that is cotton wool spot, that's how I remember that. And then microaneurysm, blood comes out, so just think like that, microaneurysm. And then neovascularization, that's it. Next one is hyperlipidemia, okay. So here, you need to know what is normal first to diagnose somebody abnormal. Okay, so normal cholesterol, less than 200 total cholesterol, okay, that is normal. HDL, that is good cholesterol, okay, good cholesterol. For male, it needs to be high because it's good, so it has to be high, okay, greater than 40. For female, greater than 50, good cholesterol. Bad cholesterol has to be in low numbers, okay? Bad cholesterol is LDL. So LDL needs to be less than 100 for everybody, okay? If they have stents, CAD, coronary artery disease, bypass done, cardiovascular disease, diabetes, okay, for those patients, it needs to be less than 70, okay? Because those are the ones, they are high risk of everything. So basically their cholesterol needs to be low. If not, they can get, carotid artery disease, they can get PVD, stuff like that. So triglyceride. Triglyceride needs to be less than 150. That's normal. So if somebody has elevated cholesterol, elevated LDL, main two high intensity statins, that is your Lipitor, Crestor. They like to ask question about atorvastatin, which is high intensity statin, okay? High intensity statin, Lipitor, Crestor. Moderate intensity, that is your simvastatin, pitavastatin, pravastatin, all that, okay? It depends. All of this, it says moderate, but it is low as well. It depends on the dose. Are you giving 10 milligram, 5 milligram, 20, 40, 80? It depends, okay? So when to start? When to start patient on high intensity? Good question for the exam. If patient has LDL, really bad cholesterol, greater than 190, okay, and if that patient has stroke, history of stroke, or heart disease, bypass, stuff like that, and their LDL is above 190, this patient is good candidate to start atorvastatin or Crestor, okay? Atorvastatin comes on 10, 20, 40, 80. Crestor 10, 20, 40. Okay. Next thing, what do you do if somebody has elevated triglyceride? For the exam, you have to remember 3 different things you have to look for. You don't treat triglyceride, okay? If the number is less than 500, don't worry about it. You tell them to do all this lifestyle modification. For less than 500, lifestyle changes is supposed to be an answer. If it's somewhere between 500 to 800 in the middle, then you can start prescribing them medicine, okay? You can do niacin, fenofibrate, niaspan, stuff like that. So those are medical management. Greater than 800, what do? You worry about something, okay? Greater than 800. You forget about all this other crap. You worry about acute pancreatitis, okay? Greater than 800, worry about acute pancreatitis. You order LFTs, you order amylase, lipase, everything. So greater than 800, check for the pancreatitis, okay? 500 to 800, prescribe medicine. Of course, above 800, you're going to prescribe medicine, but first thing you think about is acute pancreatitis. And then if that rules out, then you can start treating. 500 to 800, medical management. Less than 500, lifestyle. That's how you remember this. So lifestyle changes, what do you tell them? Low fat diet, exercise, weight loss, stuff like that. Initially, good food, lean meat, all of that. So things to remember when somebody's taking statins, tell them do not ever mix it with grapefruit juice, okay? They cannot take it with grapefruit juice. The reason being, if they take this medicine with grapefruit juice, okay, so what happens is the level of the statins in the body, it increases when they take it with grapefruit juice, or they drink a glass of grapefruit juice after 1 hour, half an hour, 2 hour, 3 hour, they take the statins, then the level of the statin is increases in the body, cause the patient to have more side effect of statins. Statins is not, good drug. Of course, it brings the cholesterol down, LDL down, total cholesterol down, but it causes 40% of the patient to have myalgia, muscles cramp, muscles pain, stuff like that. That's why if you, if patient loves grapefruit juice, and if they start taking, if they don't know what to do, they're just doing their routine, and then those patients gonna experience highest side effects of statins. That's why. The other thing is high dose of Zocor, okay, which is simvastatin, that can cause rhabdomyolysis, okay. Also, Zocor, never mix Zocor and Amyloid Pen, both of them. So you have to change either statin or change the blood pressure medicine, because Zocor and Amyloid Pen not good combination, because it can cause patient to have rhabdomyolysis. So it also affects, interferes with microlides, amiodarone, some calcium channel blockers, all of that. So statins is used for the secondary prevention. Basically, background history, patient has, stroke, CAD. I mean, normally you see patient, they have diabetes, they have stroke, they have heart attack, they have stents, stuff like that. They have some peripheral vascular disease going on, all of this patient needs to have statins on board, okay? So if patient is younger than 75, younger, then you can start them on high intensity statins. If patient is older than 75, old patient, they don't do good with high intensity statins. That's why you choose for them moderate intensity statins, okay? So also patient who has diabetes, it's a good choice of treatment. Along high cholesterol, patient who has morbid obesity, patient has metabolic syndrome, stuff like that. Statin is helpful to them. Okay, next one is murmur. So what's going on here? Very important question, in the exam, which murmur are you looking for? Okay, so systolic murmur, diastolic murmur. So what is basically murmur? What is murmur? So it's extra noise. Okay, blood is having either hard time going through, it causes noise. Okay, that's extra noise, that is called murmur. Either valve is dilated or it's stenosed. Okay, it's narrowing. Two main things. Types of murmur. You have to, this is the mnemonics from the leak book. Okay, Mr. S, Miss ARD. S, which is systolic here. Okay, remember this. Only systolic murmur radiates. So in the exam, they will tell you this murmur radiates to the neck or to the axilla. Remember this. Neck, okay, which valve is closer to the neck area? That is your aortic valve, right? If you look at the anatomy of the heart, okay, aortic valve is closer to the neck area, okay? So that's why if it radiates to the neck, you think about the aortic murmur, okay? Then we'll decide is it systolic or diastolic. Remember this, only systolic murmur radiates. So if they're telling you that, it radiates, it's gonna be your systolic murmur. Depends on where it radiates. If it's neck area radiating, that is your aortic murmur. If it's axillary area radiates, that is your mitral valve, okay? Mitral valve prolapse, it's also part of the systolic murmur. Diastolic murmur, bad murmur to have, okay? It does not radiate, but it's bad murmur to have. D, which means diastolic. MR, right here, mitral regurg. AS, aortic stenosis. This is MS, that is mitral stenosis. AR, aortic regurg, okay? So two things you need to, first of all, think when murmur question, shows up in your exam. So they will tell you the location of the murmur, okay? So they will tell you, patient has this murmur at the 5th intercostal space, left mid-clavicular line, okay? That is your PMI point, apex of the heart, 5th intercostal space, okay? And they will also tell you that this murmur radiates to axilla. That's it. You don't worry about polysystole, pansystole, nothing else. The only thing you need to know, where is it located? Does it radiate or doesn't radiate? If it's radiate, then just focus on your systolic murmur. That's it. Okay. So 5th intercostal space, this is your mitral valve. Okay. And if it radiates to the axilla, it's a mitral problem. Okay. And if it's radiate, it's systolic. So nothing else. It's gonna be mitral regurg. That's it. So if they tell you 2nd intercostal space radiates to the neck area, that is your aortic stenosis right there. The other one, you can just figure it out because it's easy. It's opposite to what I just said. It doesn't radiate, where it's located, that's all you need to know. So that's that. So another thing you need to know is grades of the murmur, okay? So grade 1, grade 2, grade 3, grade 4, 5, 6. Main one for the exam you need to know is grade 4, okay? So how do you, with your fingers, you have 4 fingers, right? So 4 fingers, you put that hand with 4 fingers on the patient chest, okay? So that time you feel thrill. That's how you feel thrill, okay? You have to put your hand on the patient chest. That is with 4 fingers, you put that on the patient chest, and that's your thrill. So remember this, grade 4, it's your thrill because you are putting your hand on the patient chest, okay? So grade 1, just barely you can hear it, you know. You get confused that is it really murmur? I don't know what's going on, you know. Second, grade 2, that is audible murmur. You can hear it, but you still stay confused, you know. Grade 3, of course, you can tell, yeah, patient has a murmur. Grade 4, you feel the thrill. Grade 5 is the age of the stethoscope. You know, you are trying to put your stethoscope on and you can hear the murmur. Age is touching to the chest wall, okay, and you can hear the murmur. Grade 6, you don't even have to touch the stethoscope. You're trying to put it on and you can still hear it without stethoscope touching to the chest, okay? For the exam, grade 4 is important. Okay, very good topic. Congestive heart failure. So basically heart failure is, you know, heart muscles is getting weak. Hearts don't have enough capacity anymore, okay? 2 types of heart failure. Either it can be systolic or it can be diastolic. Systolic heart failure, less than 40% heart squeeze. Diastolic, greater than 40%. It's called preserved EF. This is reduced EF, okay? So systolic and diastolic heart failure. So the other thing is left side heart failure, right side heart failure. Okay, main thing you need to know. L. Left-sided heart failure patient has all of the signs and symptoms related to lungs. Crackles, cough, wheezing, shortness of breath with exertion, all of that. Okay, unable to lay down because of the fluids in the lungs, stuff like that. Right-sided heart failure, all of the symptoms below the level of belly. Below the level of belly, okay, all the GI signs and symptoms. Swollen belly, swollen legs, bilateral lower extremity swelling, cool skin, stuff like that. Only one thing for the exam right here, JVD, jugular vein distension, okay, that's what they're gonna have. Right side heart failure, think about this. In the heart, left-sided heart, okay, 2 chambers, right heart, 2 chambers. So JVD, okay, jugular vein distension, that is the superior vena cava, okay, so it's a part of the superior vena cava. When patient is having right-sided heart failure, all the fluid is backing up, okay, so it's gonna go up to superior vena cava, and also it's gonna backing up to the IVC, okay, inferior vena cava, and it's backing up to IVC, and that's why it's backing up in the legs. So that's why patient is having swelling, okay. X-ray. When you order X-ray for the patient who has heart failure, you can see their heart is failing. That means the heart is dilated, okay? Increase heart size. The other thing is patient can have pulmonary edema. If patient is having acute CHF exacerbation, they have pulmonary edema. They also have bilateral pleural effusion, okay, in the X-ray. Next one is, you know, this is some New York Heart Association classification. Class 1 to 4, class 2. Class 2 patient can do, you know, all this activity, daily routine activity, but they can feel fatigue and a little bit tired and shortness of breath. That's about it. So next one, which medication you will prescribe to the patient who has heart failure, okay? So like I said earlier, right here, you can do AC inhibitors, ARB blockers, diuretics, spironolactone, and then hydralazine at the end. If patient has less than 10% EF, you know, then you can add hydralazine for African American patient. Okay, but right here, meds that contributes to the heart failure, okay? If sometimes if they already have heart failure, low heart squeeze, you know, first of all, you don't want to prescribe them calcium channel blocker. There is your Amyloid Pen, Cardizem, all of that. Heart failure patient, do not prescribe metoprolol if they are in acute exacerbation, you know, you don't do that. TZDs, that is your diabetes medicine. Those medicine, that is your pioglitazone, rosiglitazone, all of this medicine can cause patient to have heart failure exacerbation. It likes to hold on to the water and salt. That's why diabetes medicine, this one's particularly avoided in the heart failure, because heart failure, you tell the patient, avoid extra salt, avoid extra water, so you don't want to give some medication that's gonna, hold on to the water, hold on to the salt. Okay. So, of course, you're going to tell them, 2-gram salt restriction, 2-liter fluid restriction, stuff like that. Okay. Signs and symptoms, if it's left side heart failure, I already told you all that. Main thing here, you need to remember positive S3 heart sound, it's abnormal for the patient who has heart failure going on. S3 present in the heart failure cases. Okay. Next one, cardiac arrhythmias. So what's going on here? AFib, big deal here. AFib can cause patient to have stroke, okay? So how does AFib rhythm look like? It's irregular, first of all. There is no R to R clockwise pattern. It's irregular. No P wave whatsoever, that is AFib. No P wave, irregularities in R to R, that's it. So risk factors, what are the risk factors? So main thing, if patient who has undiagnosed sleep apnea or have sleep apnea but they are not using their CPAP nightly as prescribed, those patients can have more episodes of AFib, or they can have new onset of AFib. Patient who has pulmonary embolism in the past, history of CAD, left ventricular hypertrophy, the lower part is dilated, high blood pressure, all of this are risk factor to have AFib, okay? Main thing for the exam, choice of treatment for those irregular heartbeat. Beta blockers to bring the heart rate down. Calcium channel blockers also to bring the heart rate down. Digoxin, okay, increase the contractility of the ventricles, the lower part, because AFib is the problem of the atrium, okay? So, and the other thing is Amiodarone, okay? Amiodarone is a pure rhythm pill. It's gonna bring the patient from AFib to normal sinus rhythm, try to, okay? And then once they convert back to normal sinus rhythm, it's gonna maintain them in the normal sinus rhythm. So amiodarone, another consideration here, amiodarone and simvastatin increases the risk of rhabdo, okay? Main thing what's going on here in AFib, just upper part of the heart is just flickers, okay? Don't care what lower part is doing. It's just upper part of the heart is just flickers. During that time, patient's blood, in the corner of the heart, it just sits there, becomes jelly-like, and that particle can go up to the brain and cause them to have a stroke. That's why it's very important for the patient who has AFib, they have to take blood thinners, okay? To prevent stroke. Main blood thinners, they can take Coumadin, Xarelto, Eliquis, and Pradaxa. All of them is gonna work for AFib. Coumadin is high maintenance drug, so it's involve INR monitoring. Normal INR 2 to 3 for the patient who has AFib. For the patient who has prosthetic valve, the mitral valve replaced, aortic valve, mechanical valve specifically, those patients INR needs to be a little bit high, 2.5 to 3.5, okay? If not, that prosthetic valve can get clots in that, and that again can go to the brain and cause them to have stroke, or patient can die. So when somebody is taking Coumadin, you have to monitor that INR. So what do? INR less than 5, don't worry about vitamin K. You just skip the next dose and monitor, check the INR in 3 days and see what's going on, 5 to 9, it's a little bit high. Then you hold the dose. You do everything for this patient. You hold the dose, you give the vitamin K, the next dose you decrease, and then you check INR in 3 days. So you do everything, whatever you can, hold it, decrease the dose, give vitamin K, check INR, Okay, next one is SVT, supraventricular tachycardia. That is faster heartbeat. Heartbeat greater than 150 to 200. Okay, Patient does feel anxious, shortness of breath, palpitations, everything's going on here. So what are you going to tell them? So you tell the patient, bear down, okay, bear down. Try if, like, you know, have the sensation kind of if they are having bowel movements, just bear down. That is vagal maneuvers, okay? If that doesn't break their SVT, you know, heart rate continuously 150 to in the middle, somewhere between 150, about 150. They do have P wave in that EKG strip, okay? You tell them to bear down. If it doesn't break their SVT, then you consult cardiologist for the carotid massage because they are the one has to do it. Or they have to at least stand by, okay? Carotid massage or consideration, don't even massage their carotid arteries if they have recent history of stroke or TIA, okay, within last 3 months. Or when you hear their carotid artery, if they have bruit, don't do that. What does that bruit means? They may have stenosis going on, okay, it's occluded, getting obstructed, halfway obstructed, who knows. So don't do carotid massage. If you do it, okay, that plaque inside turn loose, go to the brain and have them, cause them to have stroke. So that's why. The other thing right here is a Wolf Parkinson's White syndrome. You know, it's right here, Wolf Parkinson's White syndrome. What's going on here? SA node, AV node goes both sides. You know, this is electrical system of the heart. Signal comes from here, touches here, from the here, it goes to both sides. And then ultimately heart squeeze, okay? So when SA node fires the signal, it doesn't come straight to AV node, okay? It goes all over the place, okay? That is Wolf Parkinson's White syndrome, okay? So if that patient can also have, you know, tachycardia, multiple episodes because of this is bad thing going on the background, okay? So that's that. Heart block. So heart block, what's going on here? First degree, second degree has two types, type 1, type 2, and third degree all over the place. First degree, they have this prolonged PR interval, okay? That's about it. That's first degree. Greater than 0.2 second prolonged PR interval, that's it. Second degree type 1, okay? What they gonna have? PR interval, good. Second PR interval, bad. Third PR interval, really bad. And then drop. The QRS complex just disappears. No QRS complex. That is second degree type 1. Second degree type 2, no change in PR interval. You know, it just stays steadily. Nothing's changing in that. But they have this QRS drop periodically. What is going on when they have QRS drop? Their heart ventricle doesn't squeeze that time. So just like basically kind of heart stopping. All right, I'm watching, not doing anything, you know. So heart stopping, that's kind of bad. They can die. If they have pause, that is pause probably. If they have pause for like greater than 3 seconds, that patient needs pacemaker because their own electrical system is getting bad, okay? Third degree, which is complete heart block, okay? Complete heart block. It's all over the place. There is no correlation between PR interval or QRS complex, nothing, okay? So this is the strip right here for the heart block. Look at this. This is first degree. PR interval is just longer. That's about it. You know, it's steady though, but it's just longer, greater than 0.2 seconds, okay? So this one, second degree type 1, this has PR interval, longer, progressively worse, and then drop. Fix PR interval in type 2, fix, and drop, okay? This is all over the place. No P wave, you know, QRS complex is not conjunction with there's no P wave, so you cannot really tell anything. This is the strip of SVT, faster heartbeat, greater than 150 to 250 in the middle, okay? The other thing is MI, okay? Patient can have anterior wall MI or anterior STEMI, okay? Elevation. is the most common and serious type of MI. Okay, EKG that shows elevation in V2, V4. So ST elevation can present in inferior lead, that is your initial leads in the EKG. Okay, so let me tell you right here. So all of this lead right here, it's called inferior. Okay, this is your 1, 2, 3, all of this 1, 2, 3 inferior leads. In the middle, all of this anterior leads. Okay, all of this V3, V4, V5, V6 lateral leads in EKG. Okay, so MI can happen anywhere. If it depends. If it's inferior lead right here, may suggest, you know, RCA, right coronary artery blockage. Lateral leads right here may suggest LAD is blocking. Okay. All right. Next one. Pulses paradoxicals. What's going on here? Basically, you know, you're monitoring blood pressure. That's it. That is pulses paradoxicals. So, you know, what's going on here? Blood pressure, you are checking, and then you get initial number 150. Okay, you let the patient take a deep breath. Then you keep doing this monitoring right here. A patient takes a deep breath, you know, 150 initial number, they take a deep breath and drops down to 40. Okay, then 40 is your systolic number. You go down, you know, and you got the blood pressure. Good. If patient has this pulses paradoxicals going on, you know, you took the blood pressure right here from 150 to 140 and it just dropped 10 mm at G, you know, less than 10 mm at G, it's normal. But when you took the blood pressure, you noted 150. You tell the patient, take a deep breath. You recheck, I mean, you know, just bring that thing down and it comes to 100. Oh my God, that's a big difference. Okay, so if it's greater than 10 mm of Hg difference, that is positive for pulses paradoxicals. Basically, that's what it is. If you need more information, you know, you can watch the YouTube video and they will tell you better. So why everybody's freaking out when they heard this pulses paradoxicals? Because patient can have what condition causes pulses paradoxicals? Pericarditis, okay? Tamponade, tension pneumothorax, it's this big name. That's why everybody freaks out. I'm sure there are multiple other ways to rule out pericarditis, tension pneumothorax, you know, cardiac tamponade, all of that. For the exam, you just have to remember this. They can do multiple other things, CT scan, MRI, X-ray, you know, to rule out other serious condition. They're not gonna worry about your blood pressure. Next one is infective endocarditis. Okay, so what's going on here? I had this picture. This is the picture of patient who had infective endocarditis. Okay, splinter hemorrhages. Look at this right here. Basically, infection of the layer of the heart. Okay, endo, which is inner layer of the heart getting inflamed. Splinter hemorrhages, all these tiny blood vessels are just bursting out, and then they have this hemorrhages underneath their nail. Okay, this is Janeway's lesion. Okay, it's a painless spots on the palms and feet, soles. Look at this, Janeway's lesion. Osler nodes, it's a painful nodules on the fingers and toes, that is Osler nodes. Okay, finger and toes. I'm thinking how you can remember this. Osler nodes, toes nodes, toes nodes. Just remember this if that works for you. Osler toes. Remember this way. Osler toes. They have it on the toes, tip of the, you know, fingers and toes. Osler toes. That's it. Okay, so that's that. So patient has silent symptoms of fever, chills, malaise, you know, because it's really bad condition. If somebody has all this going on, they have Janeway's lesion, Osler nodes, they have heart murmur, you know, you always want to refer this patient to cardiologist, yes, but then you have to order echocardiogram. Okay, echocardiogram, it's not ultimate test for that. They have to do TEE, okay, esophageal endoscopy. Esophageal, okay, they have to put the scope down there and check the heart. So that's what it is. You refer patient to cardiologist, or you refer patient to the ED emergency room for IV antibiotic and hospitalization. Of course, patient, they can draw blood culture over there, CBC, ESR level, it's going to be elevated when any kind of bacterial infections going on, you know. Complication, multiple complication. Patient can have stroke, they can have emboli, they can have valvular problem, myocardial abscess, anything can happen, okay? Main thing you have to remember here is if patient has previous history of bacterial endocarditis, you know, next time you're gonna be careful. If they're going for any kind of procedure, then you're gonna give them antibiotic ahead of time, okay? If they have history of endocarditis, prosthetic valve, mitral valve repair, if they have aortic valve repair, you know, any kind of surgery done in the past, congenital heart disease, cardiac transplant with valvulopathy, you know, all of this patient gonna require to take antibiotic if they have dental procedure. So remember this, any kind of nasty procedure going on, or they are working around the heart or closer to the heart, and if this patient has valvular heart disease, replaced valve, valvular heart disease with valve replacement, okay, bacterial endocarditis history, all of this patient, they're gonna need antibiotic, okay? If they're going for any kind of dental procedure, any kind of bronchoscopy, you know, it's invasive procedure involving respiratory tract, involving, so if dental procedure involving mouth, you know, bunch of bacteria in there. So all of this nasty procedure, they have to have antibiotic. Amoxicillin, 1 hour prior to procedures, 2 gram. 2 gram amoxicillin 1 hour prior to procedure, okay? Because prosthetic valve patient, you know, high risk to get that infection in the valve, okay? They're working on their teeth and doing bronchoscopy, going for it, you know, then they can get infected. So 1 hour prior, you have to treat them, basically. Okay, next one is peripheral artery disease, okay? So what's going on here? So the simple thing here, this is artery problem, okay? What artery does? This is the aorta, big aorta right there. Both sides, you know, it's coming down, bifurcating from right side, left side. So artery brings the blood from the heart and brings it to the leg, okay, all the way down, okay? So what's going on here? If this artery has blockages, you can see the yellow plaque right here, okay? If the artery has blockages, the aorta brings the blood from heart to down. Blood comes in, okay, blood don't know what to do because it's stuck, okay? When patient try to walk, blood is having hard time going through, and as soon as they try walking, you know, this artery gets pressurized, and that's why they have pain, basically. That's what the physiology going on background. So that's called intermittent claudication, okay? Patient has this intermittent claudication. They have leg pain while they're walking. All right. Patient has, can somebody mute whoever is this making noise? All right, so PAD. Sorry for that.
So,
PAD. Okay, so PAD has intermittent claudication. Patient has leg pain going on when walking. No pain at rest because when they lay down, you know, artery doesn't feel pressurized. Patient has this lower extremity cool to touch, okay? Hairless skin on the lower extremity also because no blood circulation, not enough blood circulation. They have this absent pulse, okay, because absent or decreased pulse because of the low blood circulation, okay. High risk patient, high risk for PAD, patient who is smoking really bad, you know. Main thing about smoking if they're smoking, the first thing they're gonna have problem is arterial disease. That's what they're gonna have. Second thing, they're gonna have their blocked carotid arteries. Third thing, they're gonna have blockages in their heart arteries, okay, coronary arteries. That's how it goes. PAD, carotid artery, and then heart. Diabetes is the risk factor to have PAD, hyperlipidemia, high cholesterol. That's what you see right here. It's plaque of cholesterol. Okay. Main important thing here for the exam. How do you treat all this? Okay. What do you do is get the blood pressure on all of the four extremity. That's called PVR. Okay. You order the PVR. Patient goes in the hospital or in the office setting, wherever they check this blood pressure in all four extremity. Okay. And then they get this ABI score, ankle brachial index. Okay. They get this score. And if it's less than 0.9, that is abnormal. Okay. That is, you can diagnose somebody with PAD. That is abnormal. 0.9 to 1.3, it's normal. Okay. Less than 0.9 ABI score. So what do they do here? They subtract systolic blood pressure from lower systolic from the leg, stuff like that. They minus something, and that's how they get this ABI score. Okay. So when your ABI score, if you see those ABI score is low, 0.9, you refer this patient to vascular doctor. Okay, because the gold standard, what they can do is angiography. They shoot the dye in, if it's abnormal, PVR, ABI score is abnormal, then they can do angiogram. Okay, they shoot the dye in. Okay, and then things lights up and they can tell that, okay, patient may have 60%, 70%, 80% problem. If it's about 80%, they will fix it. Unless if it's less than 80% and patient is symptomatic, they will still fix it. Okay. So main thing you have to remember, which is the medicine you can give. Platel and silastazole. Okay, Platel and silastazole. What is this? It's a vasodilator. Okay, that's why it's very important, because this artery is constricting, because of the plaque. Patient is having pain. You give them this and it dilates the artery. Advise patient stop smoking, daily exercise, and then that's it. Okay, so next one is venous. This is vein issue going on. Okay, vein from the foot, it takes the blood up to the heart. That is vein. So what vein? If they have blockages in the vein, okay, what's going on? Blood is not able to go up. So blood is not going up, okay, from the vein. So that's why patient has this edema, okay, bilateral lower extremity swellings, hyperpigmentation. They have this chronic cellulitis, ulceration. Ulcer because this water is just staying in the lower extremity, it's third spacing. So there is venous problem. Patient has dilated leg veins because it doesn't work properly. Warm skin. Okay, so here patient has warm skin. Only if they have artery problem, it's going to be cool to touch. Okay, because of the low circulation. Again, what is the definitive test? Angiography. Shoot the dye in and check the status. If it's blockage, it will tell them. Otherwise, treatment is Stental and Platel. Dilates the vein, dilates the artery. The other thing for the vein, this is just extra information. If they have vein problem going on, what do? It's called vein stripping. Bad vein, they just strip it. They just take it out, whole vein out. And then patient develops collateral circulation. Or patient, they can check the status, how many different veins are in there. The bad vein, they can take it out. And the other vein just becomes enlarged over time. That's what they do. Okay, Reynolds phenomenon. So what's going on here? It's a reversible vasospasm of peripheral arteries. Okay, so all these fingers and toes, the smaller capillaries, arteries getting constricted. Patient has this vasospasm. That's why it's gonna be cold to touch because of the no blood circulation. They're gonna have pain. Also, it's called, American plague syndrome. So patient has initially, it's gonna be paler, okay? Then it's gonna turn blue, and then it's gonna turn red when they get reperfusion, okay? So paler, then cyanosis, then reperfusion again. Paler, cyanosis, reperfusion again, stuff like that. White, blue, red, okay? Female are affected mostly, and it's autoimmune disease. Patient who is smoking, they can have this Reynolds phenomenon as well. And during winter time, it gets worse because winter time, it's a cold time, and the arteries constricts in the winter time, and that's why again it's a vasospasm. Okay, so choice of treatment: dilated, some medicine that's gonna help dilate the arteries, that's what you're gonna give them. So it's nifedipine, amyloid pen, calcium channel blocker. Choice of treatment, remember this for the exam as well. Avoid any kind of constricting thing, vasoconstrictors, pseudoephedrine, nasal decongestion, beta blockers. Avoid cold, because avoid winter basically. Stimulant, smoking, because smoking makes it worse. So avoid all that. Pseudoephedrine, dries it out when somebody is having allergies and all that. Nasal decongestion, it constricts everything, okay? That's why you don't want to give that. Very important exam question: coarctation of aorta. So look at this picture right here. What's going on? What is coarctation? This is just completely, obstructing. Maybe 80%. Blood is still going through because this part is dilated. But this part is stenosis already. Patient born with this kind of condition. This part is completely, is stenosis, okay? It's not blocked, but it's stenosis. So that's it. That is coarctation of aorta. So what is you need to know? What is the main thing? So if you check the patient's blood pressure right here, okay, because of this not block area, let's see maybe 70% or 80% block, okay? Because of that 80% block area, the blood pressure here, the heart is trying to pump as much as to go through this right here. So blood pressure in the upper extremity is gonna be high, okay? But if you check the blood pressure in the lower extremity, it's gonna be low because pressure is gonna be normalized right there, okay? Low pressure in low, high pressure in high, basically, that's what it is, okay? So systolic blood pressure in the arm is high, okay? In low blood pressure in the leg, basically. That is coarctation of aorta. So sign and symptoms: patient has irritability, it's a child, diaphoretic, dyspnea, shortness of breath, paler looking. How do you diagnose? You order echocardiogram and then you can catch this. Echocardiogram, EKG, and X-ray, okay? Main thing, metabolic syndrome is just a group of disease all together, put together, high blood pressure, diabetes, obesity, high cholesterol. Every bad condition is putting all together makes metabolic syndrome, okay? Diabetes, high blood pressure, abdominal obesity, belly girth is greater than 40 inches, hyperlipidemia. They have this blood sugar is greater than 100, triglyceride 150, HDL less than, HDL is the good cholesterol, okay? And if it's less than 40, combination of all of the above, you can diagnose patient with metabolic syndrome. Basically, when some patient, they're morbidly obese, they walk in and they have diabetes and high blood pressure, yeah, you can say that, yeah, you probably have metabolic syndrome, because of course they're gonna be big old, so that's why it's gonna be abdominal obesity, morbid obesity, they're gonna have abdominal obesity. When they have high blood pressure and diabetes, of course you're gonna look for this hyperlipidemia too, because cholesterol is gonna be high. It all goes together, okay? So 4 of these positive, yeah, they have metabolic syndrome, okay? Next one, rhabdomyolysis. So what's going on here? It's a breakdown of the myoglobin. Myoglobin is the protein, okay? It's a breakdown of the protein. It causes, so bunch of amount of protein from the body just breaking down. It goes to the kidney. Okay, kidney lets the protein out. Okay, and kidney just gets damaged because of all this extra protein. Because protein molecules is high, not supposed to go through the kidney, and it does in this case. So that's why patient has this kidney injury and it's acute. Okay, so patient have, when you get the blood work done, elevated CK, creatinine kinase elevated. Okay, patient has worsening kidney function because of the AKI, reddish color urine. Okay, what do you do when they have this multiple amount of protein breaking down, you know? So again, there are certain drugs can cause that, you know, amiodarone and simvastatin can cause that. Only high dose of simvastatin can cause that. So avoid nephrotoxic drug during those time period when they have acute kidney injury. Also, you have to wash out their system by hydration, IV fluids, 3 liter to 4 liter to 5 liter IV fluid over a couple of days. You know, that's what you have to do. IV hydration or oral hydration. Acute case, IV hydration needed. So, you know, avoid nephrotoxic drug. Okay, next one, non-alcoholic fatty liver disease. So here what's going on. So basically they're not drinking alcohol, so it's non-alcohol, and fatty liver, their liver just gets fatty. That's it. That is fatty liver disease. They're not drinking alcohol. So what is going on here? They're elevated liver enzymes. Okay, basically because it's liver related. Patient has this metabolic syndrome. Okay, that patient is high risk to have fatty liver disease. You're gonna avoid hepatotoxic drug because it's a liver condition. You don't want to make that liver condition bad. Main question you may have, patient is taking statins. Okay, it is also affecting liver. So if they have this fatty liver disease, would you stop it or you hold it, or what do you do? You know, because fatty liver disease, they're gonna have LFTs. Look at this, LFT is gonna be elevated. Okay, so you avoid statins. Okay, but when you avoid statins, when patient's liver enzymes goes up times 3 of the normal. Okay, so let's see, normal AST, ALT 20. I'm just guessing 20. So if they have 60, you know, you continue. So 20, you give them atorvastatin. Next visit they come in, liver enzyme 40, continue atorvastatin. Next visit they come in, their LFTs are 60s. Now it's time to stop. So you stop or you hold it for 3 months, you recheck it, comes back, then you start atorvastatin with lower dose. Okay, that's what you're supposed to do. But 3 times of normal, then you take actions. 2 times normal, continuously steady level, then continue that statin drug.